In medical technology, Zeiss is setting standards for more than 100 years in close cooperation with doctors around the world. Today, the company's core competencies are ophthalmology and microsurgery. The portfolio is rounded off by technologies for intraoperative radiation therapy. All products and solutions are designed to support doctors reach better outcomes for their patients. Zeiss surgical microscopes have defined microsurgery. Starting out in neurosurgery and ophthalmology, Zeiss is today bringing the advantages of magnification and visualization into further areas. The use of enhanced visualization technologies has helped make once life-threatening procedures much more effective for experienced surgeons. In ophthalmology, doctors rely on Zeiss when it comes to diagnosing, treating, and managing the most common eye diseases. The ability to see is essential of a fulfilled life. With groundbreaking innovations in optical coherence tomography, biometry, a broad choice of intraocular lenses, and 3 generations of laser vision correction techniques, doctors can help patients of all ages maintain and regain a good quality of life. The strategy of Zeiss is aligned to global challenges. Maintaining good healthcare is an achievement of our society and civilization. Zeiss wants to be the doctor's partner of choice, bringing better outcomes to doctors and their patients of all ages all over the world. Our goal is to provide everyone, everywhere, with access to medical technology. Better training for doctors and adequate treatment facilities are the key to fighting preventable blindness in all regions of the world. Fellowships help young doctors get familiarized with modern clinical care for eye diseases. Social commitment is of special importance to Zeiss, and the grateful smile of a patient is the rewarding moment we work for.
Good evening, everyone, and happy March to all. We are eager to usher in the next month of the year sans Omicron surge. Welcome to the 22nd episode of the VR channel, brought to you by the Vitreoretina Society of the Philippines. This is Dr. Joel Perez, your host, and I am delighted to share tonight's stage with my co-host, Dr. Carlo Alegre.
Thanks, Joel. I'm glad to be hosting with you. Good night, good evening to everyone who are joining us on YouTube. We have several lectures lined up tonight, and we are very fortunate to have a highly esteemed guest speaker who has lots of experience with the relatively new tool in our arsenal as retina specialists, which is the OCT angiography. He will be discussing the basics and some more clinical applications of this new technology, followed by updates on the Faricimab phase 3 studies. Then we will hear some juicy Zeiss-related updates from our guest industry speaker. But before all the excitement, we would like to take this opportunity to thank our industry partner who made tonight's episode possible, Zeiss Philippines. Here is a short message from Ms. Jill Theo, Head of Sales, Business Sector Ophthalmic Diagnostics, Southeast Asia Medical Technology Business Group.
Hello, hi everyone. I don't know why I got locked out from my laptop. Hello. Hi everyone. Hello.
We can hear you, Jill. We can hear you,
Jill.
You can hear me?
Yes, we can hear you.
Okay.
Can you open your video, please?
I don't know why I got locked out from my laptop, and okay, let me try to turn on my video, but I can't seem to turn it on. Okay, can you please give me a second? Camera.
So we would like to remind everyone that later we will be flashing the QR code on the screen. So please get your smartphones out and scan this QR code. Miss Jill, are you ready? I'm very sorry for the technical problems. We will get.
Yeah, I'm sorry about that. Give me a second. Let's see. Zoom.
So while waiting, we can advise everyone to scan the QR code to ask some questions via Slido, or and also to answer the interactive poll.
You can also post questions and comments in the YouTube chat box. So all of these questions we will try to address in the open forum portion of the session later.
Hello. Hi, everyone.
Yeah, we hear you, Jill.
Okay, so sorry about the technical glitches. Yeah, so good evening, everyone. Thank you for your patience. Can everyone hear me and see me right now?
Yes. You look
Okay,
great,
good,
Jill.
good.
You look great.
Thank you. So very good evening to everyone. Thank you for taking your Saturday evening and spend it with us. And a very warm welcome to President Dr. Harvey Wee and all members of VRSP. And of course, our distinguished speaker from Singapore, Prof. Colin Tan. And for those who don't know me, I'm Jill Teo from Singapore. I'm the head of diagnostic for Southeast Asia. I'm very happy to be here today with all of you virtually. I would love to be there with all of you someday soon. And so today, before we kickstart the meeting, I would like to quickly deliver two important messages here. And so today, I would like to share with you, Carl Zeiss Foundation was founded in 1889. The primary objective is to ensure financial security of Carl Zeiss Meditech AG through leading technology and innovation such as gold standard in our biometry, perimetry, OCT, etc. The second important objective of the foundation was to promote education, research, teaching. So we are most honored to be partnering VRSP today to promote education, learning, valuable academic and clinical exchange. We look forward to be the preferred partner in future, co-creating value and making it visible. Thank you.
Okay, thank you again to Zeiss Philippines and Ms. Teo. Again, we would like to remind everyone to bring out their smartphones to scan the QR code that is flashed on the screen. And this will also be flashed throughout the segment on the right-hand side of the screen. So through this, we can make the session a bit more interactive as you can participate in the poll that's about the topic to be discussed. Also, you can post questions and comments in the Slido app and in the YouTube chat box. Now, without further ado, let us all welcome our speaker tonight, Carlo.
Yes, Joel. Our speaker is one of the world's top experts in ophthalmology and retinal imaging. He's an associate professor of ophthalmology of Duke NUS Medical School and a senior consultant and head of the Fundus Image Reading Center at the National Healthcare Group Eye Institute of Tan Tock Seng Hospital. He completed his medical retina and retinal imaging fellowship at the Doheny Eye Institute, University of Southern California, Los Angeles, USA. He has received numerous research grants, academic awards, and scientific awards from various high-level and world-renowned societies and institutions. He has over 200 international publications and countless presentations given worldwide. His focus of interest include PCV, AMD, diabetic retinopathy, myopia and its complications, and various retina imaging techniques such as OCT and OCTA. We are indeed very fortunate to have him join us tonight. My mentor from fellowship, whom I remember as someone who takes time to teach and discuss the case even when we have a lot of patients still on queue. Please welcome Professor Colin Tan.
Thank you for the very kind introduction, Carlo. I'm trying to share the screen now. Okay, got it. Well, so very good evening, ladies and gentlemen. Good evening, Dr. Harvey Wee, the president of the Vitreoretinal Society of the Philippines, Dr. Eleanor Iguvan, the secretary, and the rest of the society. Thank you very much for inviting me to speak at this meeting. It's indeed a great honor to be able to speak to you today. And I would echo what Jill said, that we wish we could be there with you in person. I always feel that an in-person meeting is better, but hopefully the day will come soon enough when we will be able to meet each other in person. But for now, I guess technology gives us still the best option. And so for the next half an hour or so, I'll be talking to you about two topics, and I'll start off with OCT angiography. I believe this is something that many of us would have started using. Some of us may not have this available yet, and I'd like to just share with you the capabilities of OCT angiography and how this can help us in our clinical practice. Just some financial disclosures, and I'd like to acknowledge the use of many of the slides from Carl Zeiss to illustrate the points. So OCT angiography is a device that produces a vascular flow map of the retinal circulation. And essentially it uses OCT technology. On the left, you can see what looks like typical cross-sectional OCT scan. But those little red dots there are indications of areas of flow detected. And this is how OCT angiography works. It takes multiple scans at the same point, and then it processes these scans to detect differences between these images. And the difference is caused by movement of various things such as red blood cells in the blood vessels, whereas typical static structures, solid structures such as the vessel walls and the soft tissue will not change between scans. And as a result of this difference, it is able to process the image and produce this two-dimensional representation showing the vascular flow in the eye. This may look like a fluorescein angiogram, but it does not require injection of dye. It does not require the actual filters in order to take this photo, and it's a lot faster. So again, this looks familiar, but I'd just like to use this to illustrate the differences, the different layers of this different slabs that can be used on OCT angiography, right? So starting from point A, that's the vitreoretinal interface, and you can use this to detect retinal neovascularization. B is the retina itself, and this can be further subdivided into different sublayers of such as the superficial capillary plexus, deep plexus, and so on. Part C is the choriocapillaris, and D is the choroid proper. So this is an illustration of the different slabs taken in a typical eye, showing the vitreoretinal interface, the retina, the choriocapillaris, and the choroid. Now, the vitreoretinal interface, as you can see in the lower left of the screen, the purple lines there represent the segmentation zone that is used in order to obtain a scan. And you can see that this is above the internal limiting membrane and into the vitreous. So a normal eye, like on the left, would show just a blank image because there would not be any vessels there. But if you look at the figures on the right, you can see that within the slab, there's some signal on the cross-sectional OCT, and by detecting flow, it's able to determine that these are actually neovascularization, retinal neovascularization, caused perhaps by diabetes or by retinal vein occlusion. And it's very nicely seen. So sometimes if we're not sure whether these are truly new vessels versus telangiectatic vessels and so on, an OCT angiogram can be very helpful. Looking at the neurosensory retina, this is the entire retinal slab. And on the image on the left, you can see a normal vasculature of a normal eye, showing the large vessels, the finer vessels, very nicely seen, as well as the foveal avascular zone. So this is what a typical eye would look like. And on the right, a case with diabetic retinopathy, where you can see an area of capillary dropout highlighted by the arrows, which is caused by the disease process itself. In the choriocapillaris, you can usually see what looks like a homogeneous kind of pattern seen on the left column again. But in cases of AMD, where there's choroidal neovascularization, the choroidal neovascular network can be seen quite well using OCT angiography. And going into the choroid, as you know, is a very vascular area with both large and small vessels. And in a typical eye, again, the choroid may appear more homogeneous, but in the eye with neovascularization, this can sometimes be seen in the choroidal slabs as well. The size of the OCT scan has progressed. So initially, when OCT angiography machines came out, we were limited to scans of 3x3 or 6x6 millimeters. So this is a 3x3. Gives a very detailed view centered on the fovea, 6x6, 8x8, and now we're able to do a montage. So for example, this is a 14x10. It is not a single scan, but rather it takes multiple scans and stitches them together. However, it is done so quickly and so nicely that you can't really detect the borders between this. But as you can see from this, it is a very large area covered, and it's almost similar to that of typical fluorescein angiography. So this is an example of the various scans that were taken, 8x8 scans, 5 of them, in order to produce this image. And this is 5 6x6 millimeter scans to produce the 14x10 millimeter montage. And different devices, of course, do it differently, but we are able to also color code the different layers. So in this instance, for example, the red vessels are more superficial from the superficial retinal layer, the green from the deep layer, and the blue from the avascular zone. So depending on where the pathology lies, the different vessels will be color-coded for convenience and for ease of detection. So we're all familiar with fluorescein angiography and indocyanine green angiography, and they still have a very important role to play in the diagnosis and follow-up of retinal conditions. But what are the limitations? First of all, availability. Some of them may not be available in some centers, and it also requires intravenous access, which is invasive. Injecting a dye does carry the risk of allergic reactions from the patient. It is costly to the patient, and it takes time. So for fluorescein angiograms, we may go up to 20, 30 minutes even. In ICG angiography, if you want a late phase, it can go up to 30 minutes or even longer. And of course, that kind of occupies the patient's time as well as the time on your device, whereas an OCT angiogram can be done much more quickly. So here's the advantage of OCT angiography. It is rapid, it's much faster, as I mentioned. It is non-invasive. It does not require intravenous access. It does not require the use of dye injections. And it allows both qualitative and quantitative assessment of the vessels. And in many cases, the details of the microvasculature is much better seen on OCT angiography compared to fluorescein angiograms. Let's look at some examples related to common conditions that we do manage. Age-related macular degeneration is something that I'm sure all of us will see. And so these are the different slabs taken from the patient with age-related macular degeneration. The vitreoretinal interface is empty, as we would expect, since the disease process does not involve that layer. The retinal layers, often in AMD, may show some areas of increased intensity. However, that is not the main area where AMD occurs. So again, this is not the full area of our focus. However, when we look at the choriocapillaris, we can see here a very nice choroid, well, not nice for the patient, but a nicely illustrated choroidal neovascular network, which is very large, has very large vessels. Some of them can be finer as well. And sometimes in the choroid, there can be some shadowing caused by the overlying structures. And this is something that we also have to learn to pick up when we look at OCT angiograms. Here's another example of a patient on the left is illustrated by a fluorescein angiogram, the typical fluorescein angiogram showing the hyperfluorescence at 14 seconds. And on the right, the OCT angiogram showing the equivalent choroidal neovascular network. Another example here, on the color fundus photo, you see what looks very typically like AMD. And on the early and later frames of the fluorescein angiogram, you see the leakage caused by the CNV lesion. Now, when we do an OCT angiogram, we're then able to visualize the actual network of vessels, and you can see it's much finer compared to just the blotch seen on the fluorescein angiogram. You can actually see the parts of the individual vessels that make up the CNV net. Now, polypoidal choroidal vasculopathy is something that I think we see a lot in our part of the world. We know it's more common in Asians. And so this is how does OCT angiography help in PCV? Well, firstly, ICG angiography is probably still the gold standard for diagnosis of PCV. And it's also important to remember that we do need a proper set of diagnostic criteria to diagnose PCV. So not every lesion that's seen on an indocyanine green angiogram is necessarily a polyp. And it's important to apply more stringent diagnostic criteria in order to make a good diagnosis. But structures in PCV include the polypoidal lesions, as well as the branching vascular network that supplies these. And both of these are important in the disease process and in monitoring the management. So different authors have looked at OCT angiography for PCV. And essentially, we can look at the different components. In terms of the branching vascular network, visualization using OCTA is comparable to or even better than that of indocyanine green angiography. The margins are well defined and the intensity is quite uniform. In contrast, however, polypoidal lesions may not always appear on OCT angiograms, and sometimes in only about 50% of cases do you actually see the lesions. So this is important to take note that we may miss polypoidal lesions. So if you're planning, for example, a focal laser to the polypoidal lesions, or photodynamic therapy, then this will be important because you might not necessarily pick them up. And the reason, we are not very sure of the reasons for this, but it could have something to do with the flow dynamics within these polypoidal lesions. So let's look at some examples. In this example taken from one of the publications, on the left is the ICG angiogram. You can see the polypoidal lesions shown by the arrows. It's not that well seen on the OCT angiogram though. Another example where there are large, even polypoidal lesions, but on the OCT angiogram, we don't really see these. We do, however, see the branching vascular network. And if you compare figure A with figure C, the branching vascular network is even clearer than that of an ICG angiogram. And here's another example where, again, several large polypoidal lesions, but they're not picked up on the OCT angiogram, but the branching vascular network is very well seen. This is one of our cases seen in Singapore, where, again, this patient's got about 5 polypoidal lesions, not that well seen on the OCT angiogram. So there are potential limitations. Obviously, this will improve with technology, and definitely it has a role to play, but we also have to be careful of the limitations. Now let's go on to talk about diabetic retinopathy and diabetic macular edema. These are, again, conditions that are common and unfortunately are becoming more common with the increase in the prevalence of diabetes throughout the world. So this, again, the OCT angiography plays a very important role since diabetes is a vascular disease. And so being able to visualize the capillaries and the blood vessels will be very important. Here's an example of the slab taken at the vitreoretinal interface. On the cross-sectional OCT, you can see that there's some areas, some abnormalities above the internal limiting membrane. Now, sometimes we can be quite sure what it is just by looking at this, but in other cases, sometimes we're not very sure. Is that just a fibrous band, for example? Is it vascularized? And using the OCT angiogram as shown here, you can actually see that there is flow within these areas, and these are retinal neovascularization. Going on to the retinal slab, you can see areas of non-perfusion, very large areas seen superiorly, and even between the spaces nearer the vessels, you can see areas that have both telangiectasia as well as areas of capillary non-perfusion. So very nicely visualized using OCT angiography. In the choriocapillaries, you often don't see very much in diabetic diseases. In some cases where, for example, this patient had focal laser before, you can see the effects of laser scars, but I guess that wouldn't necessarily be our biggest priority at this point. So not the most important focus. And so the slab that you take, that you visualize is very important. In this case, the visualization of the choroid also perhaps shows examples of laser scars, but nothing else that's really helpful in managing diabetic eye disease. Remember I mentioned the color coding, and that red is the most superficial. So again, you can see the various color coding of the vessels here. Here's another example of a patient with neovascularization at the disc. And on the fluorescein angiogram at 1 minute 48 seconds, you already see these large areas of leakage because, as we know, new vessels are very leaky. So it doesn't, we know that's new vessels for sure, but we don't visualize it very well. But if you just look at the OCT and angiogram, we can actually see the individual vessels that make up this neovascular network coming from the disc. And so it's at least nice to visualize, although of course, I agree that even with the fluorescein angiogram, we would already know what it is. Probably clinically, you could tell what it is, but if you want to visualize it and see whether it's, for example, regressing or increasing, then the OCT angiogram will be very helpful. Here's another example taken from another series where the patients has, as you can see on the fluorescein angiogram, areas of non-perfusion, especially temporally, as well as neovascularization right at the edge of the area that has been lasered. So the OCT angiogram on the top right, again, illustrates this very nicely. Retinal vein occlusion, though not as common as diabetic eye disease, is something that we do see. And again, OCT angiography does play a very important role. So again, remember that there are different slabs you can use. In this case, the vitreoretinal interface again shows the abnormal vasculature. These are retinal neovascularization as a result of the ischemic process. In the retina itself, there are areas of non-perfusion. This is especially in the superior temporal areas, and you can see the remaining large vessels, but the small vessels and the capillaries have all gone from this area. So we're trying to target, for example, for some laser photocoagulation. Then this helps us to guide us where to aim the lasers. The choriocapillaris in this case doesn't show anything. As I mentioned, retinal vascular diseases tend to be more within the retinal layers, and you may not expect much in the choriocapillaris itself. And in the choroid, you also see it looks fairly normal in this case. So again, the color coding can be useful to show the involvement of the different layers, although sometimes it might be more useful to look at the individual layers, at least initially, so as to get your bearings. So here's another example of a patient with a branch vein occlusion, where we can see that superiorly on the fluorescein angiogram, there's areas of leakage, as well as a bit of abnormal vessels. And looking at the OCT angiogram, we can see very nicely that the vessels there are a bit more telangiectatic. There's spaces in between with capillary dropout, and the edges of the foveal avascular zone in the superior half is a lot more irregular, and this reflects the effects of the branch vein occlusion. So to conclude, I would say that OCT angiography is definitely an exciting technology that's in our midst already. It's applicable and used in clinical practice in many parts of the world. It has significant advantages over conventional imaging, chiefly the convenience, the speed, and the fact that it's non-invasive. There's, of course, always potential for improvements in technology, which we are all very excited about. But even today, I think I would say it's a very useful, if not indispensable, tool for use. And I'm sure that it will become even more prominent in its use in the near future. So thank you very much. This will be the first lecture, and I'll be happy to take any questions.
Thank you, Prof. Colin, for that very informative lecture. We will now open the floor to questions. You may post your questions in Slido and in the chat boxes on YouTube. While waiting for the questions to come in, let's take a quick look at the results of the poll that we conducted earlier. So, do you have OCTA in your main area of practice? About 80% of the viewers said yes, so that's quite interesting. Let's take a look at the other poll. In what specific cases do you prefer to request for an OCTA? So these are some of the responses. We have diabetic macular edema, PCV, unexplained vascular retinopathy that is equivocal on FA, or for those where the dye is contraindicated. For monitoring of choroidal neovascularization and diagnosis of RAP, again, PCV, AMD, and patients with nephropathy and pregnant patients for repeat follow-up exam, and diabetic macular ischemia. Okay, thank you for the responses. Prof. Colin, do you have any comments on our response from the audience?
Well, yeah, I think this is firstly is good to know that 80% of the audience has access to OCT angiography. I know, of course, that sometimes it's not that easy. You have to factor in budgets for your various institutions. But I think as retinal specialists, I think we should really make a push for those who don't have it. This is an important area to push for. And I'm sure companies like Carl Zeiss will be very also keen to work with the institutions to try and see how they can make this available. In terms of the indications, I agree with these, and perhaps I did mention this in the advantages, but I think it's a very useful point to emphasize that in cases where fluorescein angiography or ICG angiography is contraindicated, and examples shown where patients are pregnant, for example, then an OCT angiogram is the next best thing. If you can't do an actual fluorescein angiogram for the dynamic phase. So that's something that we didn't have before, and that's very useful to consider. Carlo, I don't remember whether you were still with us when there was this patient that was pregnant and had some subretinal fluid. So, we also monitored her periodically with OCT angiography. And the good news is after her delivery, she's better now, but she never actually got an angiogram eventually since she improved after the delivery.
Okay, so thank you, Prof. Colin, for that those clarifications. So actually, we have some questions. So for the first question, can we appreciate CNV regression for patients on anti-VEGF treatment on OCTA?
Right. So that's a very good question, and yeah, I did have some slides on this, but because of the issues of time, I decided to focus more broadly on the applications. But yes, it has been applied. We can, since OCT angiography is non-invasive, it's quick, we can do this almost every visit if we really choose to do so. Although I think that might not necessarily be, for every patient, but we can do it more frequently compared to typical angiography. It can be used to monitor. So there have been reports that have shown the CNV network regressing both in area as well as the vessel density over time following treatment. And they even nicely monitor, how it sort of comes back after the effects of the anti-VEGF wears off, and then sort of regresses again with this. The one thing I would urge caution in doing so is that you must make sure that the segmentation on the OCT angiograms are properly done. There can be segmentation errors caused by different artifacts, and this can potentially result in areas that are being excluded, so that the lesion appears smaller than it actually is, definitely compared to the previous scan or a future scan, or areas that are sometimes included incorrectly. And all of these can actually affect the assessment. So it's very important to also assess clinically and to be aware of the limitations of the OCT segmentation.
Thank you. Here's another question. So Prof, you mentioned about segmentation artifacts. So the next question is, what artifacts are commonly seen in OCTA?
Right. Yeah. So that's a good thing. Very good question. And actually, there can be almost an entire talk of equal length on the same topic. So perhaps we, in a future talk, we might be able to cover that as well. I'm sorry I didn't really mention that too much. As I said, there was a lot of ground to cover. But the typical artifacts, segmentation, I've already mentioned, and this is something that's very, very important. Sometimes, even if it segments, it could appear, abnormality could appear in different layer, in the so-called, be perceived in the wrong layer of the retina. So it's very important to assess the segmentation, but it is time consuming, obviously, especially if you wish to correct it. Other artifacts will include motion artifacts. So because the OCT scan does take longer, they're doing multiple scans. So the scanning speed has increased, but because they are taking multiple scans, some patients, we all know, can't comply very well, fixate very well. So they tend to move their eyes. And whilst the different devices do have tracking to overcome this, it is sometimes not enough for patients that really move around. And so what's going to happen in that case is that the various scans will not get well taken. There'll be artifacts, and these artifacts can sometimes be mistaken for areas of abnormality. I mean, a very important point, when OCTA first came out, just to illustrate, I remember this case where another doctor saw an OCT scan that was full of artifacts, but it appeared very black, and concluded that this was very ischemic and ordered a PRP for the patient. The doctor who was the primary doctor in charge of that patient happened to just ask me as I was passing through the clinic. And I looked at the scan and I said, well, it's full of artifacts, I agree, but I'm not convinced it's ischemic. So, literally ran to the laser room and said, stop the laser. So that's how scary it could be. Other artifacts would be things like projection artifacts, where because of the way the scan is done and the way the images are processed, again, some areas a lesion in one area can appear to be in another area. So I think, but probably to do it full justice, probably this should be covered in an actual discussion, in a full discussion with actual illustrations.
Thank you for answering that, Prof. Colin. So in view of these artifacts, we should be careful in interpreting OCTA. So the next question, Prof, is what is the utility of OCTA in MACTEL?
Right. So, well, we know MACTEL is a very interesting disease with not much treatment options, right? So, but they do have some characteristic patterns, which we can, of course, see on the both on fluorescein or sometimes ICG angiography. OCTA can be useful in showing us the abnormal telangiectatic vessels around in the parafoveal region. So, which sometimes, if there's a bit of leakage, this is obscured in the using fluorescein angiograms. And also, if there was any abnormal choroidal neovascularization that arose in that area, if we're looking for that, I think OCT angiography would be helpful in detecting that as well.
Okay, here's another question. Prof, in your clinical practice, do you mainly rely on qualitative assessment using OCTA, or do the quantitative parameters play a role as well in managing your patients?
Right, that's a good question. I would say that right now, qualitative assessment is still the mainstay. What I would really be looking for is to either help me make the diagnosis, see whether the lesion is still there if I'm monitoring, see whether it's regressing or getting worse. In terms of quantitative parameters, I think it is definitely has a role to play, but it'd be good to, as the devices get more and more of these quantitative measurements added to the software, I think that will be helpful. Right now, there's of course a lot of research work on things like vessel density and vessel areas and so on. But I'm not sure that this is something that would be applicable in just everyday practice. I mean, as you know, also, unless we can get these measurements accurately and fast, we have so many patients that sometimes just a qualitative assessment is the best we can use for this for.
Thank you for that, Prof. So the next question is, how do you decide on the parameters for segmentation of the various layers?
Right. So these are usually preset by the equipment manufacturers. Many of them now give you the option to set specific sort of custom slabs to your specifications, but they are usually preset. They do have preset settings, and usually these are based on measurements. So on the slide that I showed earlier, I perhaps should have pointed that out. There were some measurements in terms of microns from a reference surface to measure the distance, the upper and lower borders of the slab. So, and again, that's important because in some cases where, for example, if there's very gross edema, then the slabs may actually cut off parts of the retina that's because of the increased thickening.
Okay, here's another question. Do you request OCTA in CRAO or BRAO?
I've done so, but it hasn't been really that useful. I mean, usually clinically, you know what's going on. When you look at it clinically, just based on the patient's history, sometimes you guess what's happening, but when you examine, you already see it. So it probably isn't that useful because we know what we have to do for these patients already. Yeah, so I wouldn't, there probably other priorities. I probably wouldn't necessarily rush to do it. I might do it as a baseline if everything else, if the patient's otherwise stable and other measures have been initiated, but not the biggest priority for this condition.
Thank you for answering the questions, Prof. Unfortunately, that is all the time we have for this segment. Thank you for sending in your comments and questions. For any questions that we were not able to get, we will certainly try our best to address them and send you the answers. For now, let us move on to the next talk, which discusses a new drug to battle retinal diseases. Prof. Colin, you may now take the floor.
Okay, thank you very much. Let me just start the slide sharing. Okay, I hope everyone can see this, and thank you once again. This is yeah. Oops, back on. So thank you. We'll be changing tracks now. So previously we talked about using the devices and how this can help us in diagnosing and monitoring patients. Now let's switch tracks to talk about drug treatments and new developments. So I'll be talking about the phase 3 clinical trial results for Faricimab, which is a drug that's coming on the market, I think, in most of all our countries very soon. So this is an exciting drug, and I'd like to share with you what this drug's about, as well as how this may be helpful. So again, just my financial disclosures, and that just to mention that practically all the slides here were used with permission from Roche for since these are their clinical trials. So we know that age-related macular degeneration and diabetic macular edema are major causes of visual loss, and the prevalence is increasing because of both the aging population as well as the increasing prevalence of diabetes mellitus in many countries. So anti-VEGF treatments have come into play for over a decade, and they're obviously very effective. They've given our patients hope, and which is very important. But these are chronic diseases, so they require long-term management and follow-up. And so treatment presents significant financial burden on both the patients and healthcare system. And as the treatment burden on both patients and healthcare providers cannot be underestimated. The number of injections, it just keeps increasing year on year. And both for the patient and for the healthcare providers, the question is this sustainable? So when we look at the clinical trial results, we essentially have seen for AMD that there's a gain in vision with treatment, but as patient goes on over time, the vision does tend to drop. In actually clinical trial-based patients, the vision drop is less severe, but in real-world studies, it can drop quite quickly, as shown by the lower line blue. So the challenge for us is to see whether there's anything in terms of treatment regimes and drugs that can give us greater visual gains, that can help us maintain these visual gains for the patient, and ideally reduce the treatment burden for the patients as well. So in the normal functioning of the retina, there are normal levels and ratios of Ang1, Ang2, and VEGF-A, which promote vascular stability. Now, I understand that just a few weeks ago, my friend Dr. Paulo Silva gave some talk on a lot in the details of this, so I won't spend too much time. But I'll just mention that both VEGF-A and Ang2 are synergistic but not in a good way. So when there's conditions of cellular stress, there's an angiogenic switch which upregulates both Ang2 and VEGF-A, which leads to neovascularization, inflammation, and becomes a vicious cycle. So with this angiogenic switch, it drives vascular instability through different ways. And it's important to realize that these cytokines often in a normal eye exist in a balance. And so if the needle switches over to the left, then that's when the disease process gets worse. So Faricimab is the first bispecific antibody that independently binds and neutralizes both Ang2 and VEGF-A. So binding the VEGF-A is like the other anti-VEGFs that we're familiar with, but Faricimab also has the advantage of binding Ang2, which then allows Ang1 to occupy the Tie2 receptors, and this would promote vascular stability and suppress inflammation. So this is just a summary of what I just mentioned, that Ang1 is in a way the good cytokine. Ang2 and VEGF-A, when they increase in disease process, lead to vascular instability, and our goal is perhaps to inhibit both of these. So with this in mind, and with having good results from phase 2 studies, they went on to do pivotal studies, phase 3 studies for both DME and AMD. So for DME, the studies were Yosemite and Rhine, and for AMD, it was Tenaya and Lucerne. And it's interesting that the design of the study was made to reflect real-world practice with the aim of reducing treatment burden and, of course, maintaining the visual gains. So first, let's look at diabetic macular edema. So this is the study design of the clinical trial. The patients, there were three arms, equal distribution amongst the three arms. There was an initial loading dose of faricimab, after which one of the arms went to 8-weekly dosing till the primary endpoint. Another one went to PTI, or personalized treatment interval, which I'll talk more about in a minute. And the comparator arm was aflibercept 2 milligrams with a loading dose followed by 8-weekly as per label. So for faricimab, for those that went on the PTI algorithm, they received 4 initial 4-weekly doses through week 12, after which they were then assessed based on this change in some central subfield thickness, as well as the change in visual acuity. And in summary, if the central subfield thickness was improving, the interval was maintained because they could still potentially improve further. If it was stable and the vision had either improved or did not worsen by that much, they were extended, the intervals were extended. However, if the central subfield thickness had increased beyond a certain point, accompanied with some visual gains, then the intervals were cut down, and the severity of this was determined by the extent of the change in central subfield thickness as well as the change in visual acuity. So this chart just illustrates the baseline parameters. In summary, all three treatment arms were comparable in both Yosemite and Rhine. Now, when we look at the visual gains at 1 year and at 2 years, we find that all three arms had very similar gains in each DRS letters, and there was no significant difference between any other arms. What's interesting is the treatment frequency at week 52 after 1 year. If you look at the chart here, you can see that the proportion of patients who were on 4, 8, 12, and 16 weekly treatments are illustrated by the percentages. And what's important is if you look at the dark green on the right of the pie chart, that's the 16 weekly. Over 50% of the entire population was on 16 weekly at week 52. Now that's quite impressive. If you look at the proportion who were either 12 weekly or 16 weekly, this rose to almost 3/4 of the population. 71%, 73% of patients were on either 12 weekly or 16 weekly at week 52. And looking at week 96 results, 78% in both of them were either 12 weekly or 16 weekly. So this is potentially a very exciting development because we can maintain a proportion of patients with much longer treatment intervals than what we are used to with some of the other drugs. In terms of patients who gained 15 or more letters at 2 years, the proportion was similar amongst the treatment arms. And conversely, the patients who avoided a loss of 15 or more letters was again similar between the arms. So no difference. There was a greater reduction in the central subfield thickness for both the faricimab arms compared to aflibercept, both at 1 year, and it was maintained through the second year as well. You can see the chart here illustrates it quite nicely. And so the adjusted change in best corrected visual acuity was similar. The patients, over almost 3/4 of patients could be maintained on 12 weekly or 16 weekly treat dosages. And there was a greater reduction in the central subfield thickness, with more patients achieving a dry retina without intraretinal fluid quite early in the course of the treatment. And this again illustrates the absence of disease over time in both studies. This chart here on the left is quite interesting, and allow me to walk you through. So the green cells indicate patients who are on 4 weekly. The orange is 8 weekly, 12 weekly is purple, and the pink is 16 weekly. And these are individual patients in each of the studies, and they just stack them up to show the progression of patients over the course of the study. So you can see right at the top, some of the patients had the mandatory 4 weekly doses, and then they went straight to 8 weekly, went to 12 weekly and 16 weekly, and they stayed throughout for 52 weeks. However, so lower down the chart, you do see that some of them perhaps maintain at orange even through 52 weeks, where they had to stay at 8 weekly. And right at the very bottom, there are some, of course, who remain on 4 weekly. So there is some variability in the response of patients. And this is something I think we know as clinicians, that there are differences in how patients can respond. And what's important is we want to know, perhaps it would be useful to know which of these patients can we possibly identify them, and is there perhaps something we can do to try and mitigate this. But we do still see that a lot of patients do go very quickly to 8 weekly, 12 weekly, and 16 weekly treatments. How about the side effects? So there was no important safety signals. The rates of side effects were low, and it was comparable between faricimab and aflibercept. Very importantly, the frequency of APTC events, as well as vascular occlusive events or vasculitis, were very low across all the arms. So in terms of diabetic macular edema, faricimab was able to maintain comparable visual gains and maintain this through year 2. There was improved anatomic outcomes in terms of the change in the central subfield thickness, absence of diabetic macular edema, absence of intraretinal fluid, and very importantly, 3/4 of patients or more could be maintained on 12 weekly or even longer. And there were no cases of retinal vasculitis or occlusion. So there's an ongoing extension study to generate 4-year data, and I'm sure we all look forward to this. Now let's switch tracks now to talk about age-related macular degeneration. So this study, the design was slightly different. They also had initial 4 loading doses, and they were compared against aflibercept with 3 loading doses and 8 weekly after that, as per label. But for the AMD cohort, the patients were evaluated at week 20. So if you look at the third row here, at week 20, if they had disease activity, they were then assigned to receive faricimab 8 weekly throughout the first year. If they did not have disease activity, they were assessed again at week 24. If at that time they had disease activity, they then went on to a 12-weekly regimen. If at both week 20 and week 24, they did not have activity, they then went on to a 16-week regimen. So this is the design of the study. Again, the baseline parameters of these patients were comparable between the treatment arms. And this illustrates the visual gains for these patients, showing that they were comparable to the aflibercept arm through 52 weeks. In terms of gains of 15 letters or more and avoiding 15 letters or more of vision, this was again similar between both arms. And again, very importantly, almost 80% of them could be maintained on 12 weekly or 16 weekly treatments. In this case, about 45% were on 16 weekly treatments, which is a lot better than some of what we're achieving with some of the other drugs. So very promising results for our patients. In terms of the change in the central subfield thickness, it's illustrated here, where it's definitely comparable, perhaps even a bit better compared to the aflibercept arm, where you can see the sawtooth effect, which has been described previously. Again, in terms of the side effects, there was no important safety signals. And in terms of retinal vasculitis or retinal occlusive events, it was a very low or no cases in all of these studies. So very important finding in today's environment. So just to summarize, faricimab has been shown in phase 3 clinical trials to be useful for both DME and neovascular AMD. For DME, there was improved anatomic outcomes. For AMD, there was improvements in both the anatomic as well as the central subfield thickness. Between 45 to 52% of patients could be maintained on 16 weekly dosages, and 72 to 80% of them were on 12 weekly treatments. The safety profile was very good. It was comparable to other established anti-VEGF drugs with low rates of intraocular inflammation and no cases of vasculitis or occlusion. And this is very useful, and I'm sure we're looking forward to having this drug to add to our armamentarium. And of course, we also want to see the longer term results of these studies. So I think that's what I'll have to share about faricimab. Thank you very much, and we can probably save the rest of the time for some questions.
Thank you very much, Prof. Colin, for that very nice talk. It's very good to know that the safety profile of faricimab is good and it's well tolerated and there's not much side effects. So I think we have some questions. For the first question, faricimab being new in the industry, are you comfortable in using it for your patients?
Good question. Well, obviously, with different people will react differently to a new thing, right? It's like some people rush out to buy the newest iPhone, and some others will just take a wait and see approach. I think obviously the results from clinical trials are useful, and I'm sure there'll be more reports coming in. In brief, yes, I'm comfortable based on what I'm seeing in terms of the safety profile. I think I'm definitely comfortable to give it a try. And the results in terms of both the gains as well as, very importantly, the ability to maintain longer treatment intervals. I think that's very, very helpful. Obviously, I will want to have direct experience administering this drug for patients, and I'll be watching the first patients very closely. But yes, I'm definitely keen to and looking forward to being able to use this drug.
Thanks, Prof. Here's another question. Are you worried about more geographic atrophy in faricimab due to drier retina seen in the studies?
Right. That's an interesting question. Well, I'm sure they'll be looking at additional analysis on the imaging from these various studies, and so hopefully they will be able to answer that question. In terms of geographic atrophy, yes, I know there's the theory that excessive drying of the retina may contribute to this, but we also know that maintaining fluid in the retina or having fluid that's still persistent and sometimes over time cause retinal loss as well. So I think it's a balance between the two. And really it's always individualizing the management and doing this in partnership with the patient to see firstly whether their vision is dropping, whether they're affected by it, how much fluid is there, how bad does it look. So it's something that I'll be looking for, but I think in general, if I'm able to dry out the retina, it improves the vision for my patient, then I think that will be helpful.
Thank you for that answer, Prof. Colin. I think everyone wants a dry retina. Sometimes they attribute the geographic atrophy to the natural course of the disease, but I think every one of us would just want to dry that out. So for the next question, it is claimed that faricimab has a good safety profile. I know that in your lecture you have mentioned the good safety profile, but would there be any adverse events that we should be worried about? Any sight-threatening complications that you have encountered?
Right. Well, I haven't had the opportunity to use the drug myself, so I can't really comment directly. Based on what I've seen from the results and in discussions with other colleagues, I think there is a good safety profile. There isn't anything that sort of stands out in terms of having this additional risk compared to other anti-VEGFs. Whenever we administer anti-VEGF, we know the standard risk we have to tell our patients. I don't see anything new. We would, of course, be looking out for this, and if there were any, we would definitely want to know about it and would have to take that into account. But fortunately, so far, the data looks quite safe. Remember, they've had phase 1, phase 2 studies as well. So fingers crossed that, if it's the same, if it maintains this profile, then I think we're good to go.
Here's another question. What was the reason for loading dose regimen for faricimab?
That's a good question, and I think probably the best directed to either the steering committee for the exact thing. I would think that I'm probably from the results of the earlier phase 2 studies, they may have identified that that's when they get more effect. I'm just guessing, since I wasn't involved in the steering committees on those studies. And possibly, for example, the diabetic, where the aflibercept went to 5 loading doses because of the label for diabetes, perhaps they wanted to have some similarity in that. But I'm only guessing. So I'll make a point to ask them when I next talk to them.
Okay, so I think we've answered all the questions. For a while there, I thought we were changing from a 3 loading dose to a 4 loading dose regimen already. But anyways, yeah. So thank you, Prof. Colin, for answering the questions. We are very grateful that you've joined us and for this evening. We appreciate your lectures and we thank you very much for accommodating the numerous questions from our viewers. Prof. Colin, is there anything you'd like to say to the audience or to our sponsors?
Well, firstly, I think, again, thank you to the Vitreoretinal Retinal Society of the Philippines for organizing this and for inviting me. It's a great honor and always a pleasure to meet all of you. Thanks to Carl Zeiss for sponsoring this thing. I've enjoyed working with them and obviously looking forward to this. And as we've said before, I think we all look forward to the day when we can all meet our friends and colleagues in person. So either to have you come out to Singapore or for us to come to the Philippines. So it's been a pleasure, and I'm looking forward to the next talk as well. I'll be online.
Right. Thank you, Prof. Colin.
Thank you.
Let us move on to the last segment of this session. Our next speaker is the Regional Product Manager for Southeast Asia Ophthalmic Systems Medical Technology Business Group of Zeiss. He will be giving us juicy Zeiss-related updates. And without further ado, please welcome Mr. Michael Morales.
Good evening. Hi, I'm Michael Morales. I'm the Regional Product Manager for Ophthalmic Diagnostics, handling Southeast Asia. And today, I'll be presenting the new innovations in OCT. OCT technology have come a very long way to achieve these kinds of innovation. And each generation have given us a remarkable advantage towards the ophthalmic industry, from the time domain, spectral domain, and swept source. Here is the overview of OCT technology history. In 1996 and in 2002, the time domain was released. And this is where the Stratus OCT becomes one of the most successful OCTs in the market, selling 6,000 units worldwide. In 2005, Visante OCT was also released. This is the first anterior segment OCT that is coming from the time domain platform. 2007, the first spectral domain from Zeiss was released. This is the Cirrus 4000. And in 2013, the Cirrus 5000 was released. Then in 2019, the Cirrus 6000 was launched in the market. So this is the same platform coming from the Cirrus 5000, but adjusting the speed from 68,000 A scans per second going to 100,000 A scans per second. Then we have another technology, which is swept source. So in 2016, Zeiss have released their Plex Elite 9000 platform, which is a swept source, and this is scanning 200,000 A scans per second. But this is not commercially available because this is the purpose of this machine is for research. OCT nowadays is being considered as one of the major diagnostic tools. For example, in retina, we can see different layers and different pathology using the OCT. And also, we can use the macular change analysis to track the changes over time, for example, in diabetic retinopathy, and as well as the response in anti-VEGF therapy. OCT also is being considered as a major diagnostic tools in glaucoma, such as giving us a structural information of the retina, particularly the RNFL assessment, and the optic nerve head. Also, it can give us an information coming from the ganglion cell analysis, which is very important for the early detection for glaucoma. OCT, being a posterior imaging device, can now be used as an anterior segment imaging by attaching a lens. Now, it can give us more information for the anterior portion of the eye. This includes anterior chamber measuring, multiple measurement tools, HD corneal scans if we want to see any pathology from the cornea, non-contact assessment of iridocorneal angle, pachymetry, and epithelial thickness mapping for keratoconus. As we have discussed before, OCT technology have come a very long way, and now it is showing again a new innovation. And in the next chapter of posterior imaging is OCT angiography. Over the last 15 years, the OCT technology has made substantial advances, such as the scanning speed, the measurement tools, and also the software upgrades. The spectral domain OCT has been rapidly adopted in ophthalmic imaging applications for both clinical and research purposes. Now, the newest addition in this technology is the OCT angiography. This is a non-invasive diagnostic method through which the vascular structures of the retina and choroid may be visualized in 3D without the need of any contrast or agent injection. Now let's discuss shortly the OCT angiography. The OCT angiography is a non-invasive technology that allows the detection of blood flow and 3D reconstruction of blood vessels using an OCT signal. This is to identify retinal circulation using intrinsic motion of blood cells inside the vessel. Unlike the OCT, it acquires functional rather than structural information, usually viewed in fast projection. When unlike the angiography, it requires no contrast medium and the data is three-dimensional and depth resolved. Here are some important information that we need to know regarding OCT angiography. First, the OCT angiography must have a good algorithm. Second, the OCT angiography must have a high-quality OCT system. And then third, it should have a fast tracking. And also at fourth, it should be easy to use. So in a nutshell, OCT angiography is a non-invasive dye-free angiography with real-time tracking system and have a single scan simplicity. This transforms the routine retinal care into a new innovation. So how does the OCT angiography works? OCT angiography works using an OMAGC or optical microangiography complex, which detects the motion of the red blood cell within sequential B scans performed repeatedly at the same location, usually 4 times. The depth of the retinal vascular color coded is ease of visual assessment. Now, by using this technology, it is also using a real-time tracking using our fast track. Now, this detects motion artifacts and also eliminates eye movements when the patient blinks. It is very useful as well when giving some information regarding different layers of the retina. After the scanning is complete, the OCT angiography will now produce maps, which we call the angioplex map. This will create a 2D representation of a retinal vasculature or different layers of the retina. As you can see here, you have 4 pictures that have 3 major layers, which is superficial retina map, which is color red, the deep retina map, which is in color green, and the avascular map, which is in color blue. Now, the combination of these 3 major layers will be the color depth retina map. Now, the color depth retina map combines the superficial, deep, avascular retina maps and allows for depth visualization of retinal blood flow. Also, in OCT angiography, there's some algorithm, which is what we call the angioplex metrics. Take, for example, in diabetic retinopathy. In diabetic retinopathy, retinal vascular density is known to be affected. And diabetic retinopathy is also characterized by an irregular large foveal avascular zone. So the angioplex metrics objectively assess the changes of this pathology over time. This is by using the vascular density and the perfusion density. Now, this helps us to inform the patient with early diabetic retinopathy changes. And we are referring to the automatic detection of foveal avascular zone and also the circularity. Now, in angioplex metrics, we have parameters, which is being used in the 3x3 and the 6x6 scans. First parameter is the foveal avascular zone parameters, which is using the area, the perimeter, and the circularity. Second parameter is the density parameters, which is using the vessel density and the perfusion density. The absolute and percentage changes over time for all the above parameters are available in angiography change analysis, which you can see below the screen. In OCT angiography, we have different scans. We have the 3x3, the 6x6, and the 8x8 millimeter scans. Also, the OCT angiography can produce a 14x10 and a 14x14 using a montage. For expanded field of view, for the angioplex montage, we are using 5 8x8 millimeter OCT scans. Then it will be combined after the different scans and form the 14x14 millimeter montage. Here is an example of a 14x10 millimeter montage. So here we can see some presence of the microaneurysms and some ischemias of the retina. So here you can see the color depth retina map is activated, wherein we can see the combination of the red, green, and blue areas. OCT angiography can also be used in glaucoma applications. We are quantifying the radial peripapillary capillaries, or the RPC, from ILM to RNFL. This is what we call the angioplex metrics for ONH. We are using the capillary perfusion, which is the percentage of an area that contains perfused vasculature, and this can provide useful information for detecting and monitoring glaucoma. Second is the capillary flux index. Capillary perfusion weighted by the intensity of the flow signal, and this may help physicians also to monitor glaucoma. We need to remember that OCT angiography or angioplex is also an adjunct to FA and ICG. Some will use it as a substitute immediately or the diagnostic tool of choice. We have to remember that OCT is already used alongside or instead of an FA or ICG. FA and ICG are still great safe tests. Zeiss have great solutions for this. We also need to remember that angioplex is not a replacement for FA. We need to understand that FA is still the gold standard for retinal imaging, and has still this OCT angiography has still some limitations for now. Angioplex can help the retina and non-retina doctors to diagnose. This is by the ease of use by non-invasive procedure or no dye at all. With so many informations that we have from the OCT and other modalities, putting it all together is the next generation in multimodality care. This is what we call the Integrated Diagnostic Imaging Platform, or IDI. This is the next big thing in software-driven imaging solutions. This is combining and presenting clinical information from multiple Zeiss devices into a single integrated point of view or monitor, harnessing the power of perimetry, OCT or OCT angiography, and ultra-wide field camera. Here is one example of the IDI or Integrated Diagnostic Imaging, which we combine the ultra-wide field imaging and the OCT angiography. As you can see, we have a shot at the background of the Clarus 500 and 700, and also we have the Cirrus OCT angiography or the angioplex. And you can find different layers of the retina and also the B scans. As we have discussed the new innovations in OCT, we know that we are still scratching the surface, and there's still a lot to learn with these kinds of technology. With this, thank you very much for listening.
Thank you, Mr. Mur.
Good evening. Hi, I'm Michael Morales. I'm the Regional Product Manager for Ophthalmic Diagnostics, handling Southeast Asia. And today, I'll be presenting. Thank you very much for inviting us on this event, and we hope that everybody learns something.
Okay, thank you. We'd also like to thank Prof. Colin. Do you have any farewell remarks?
Oh, yeah. Yeah, thank you everyone for tuning in on Saturday. It's been a pleasure speaking to you, and see you soon, and hopefully in person. Stay safe, everyone.
Okay, thank you, Prof. Colin. To summarize our evening, OCT angiography is a new and evolving retinal imaging technology that has the advantage of being rapid, non-invasive, dye-less, while allowing both qualitative and quantitative assessment of retinal and choroidal microvasculature. Its use is vital in detecting pathological changes within the vitreoretinal interface, neurosensory retina, and choroidal vessels such as ischemic areas and ingrowth of neovascular structures. Advancement in technology now allows for wide-field vascular assessment and color coding of the different layers to allow for better detection of retinal and choroidal pathologies. Clinical application of OCTA is valuable in diseases such as PCV, AMD, diabetic retinopathy with macular edema or ischemia, and retinal vein occlusions. Faricimab is a bispecific antibody that binds and neutralizes both angiotensin II and VEGF-A, whose upregulation causes vascular instability. Phase 3 trials of faricimab for DME, namely Yosemite and Rhine, and neovascular AMD, namely Tenaya and Lucerne, demonstrated that it has similar visual gains with aflibercept, even with extended dosing up to 16 weeks. Faricimab showed a good safety profile and low rates of intraocular inflammation. In the future, faricimab offers prolonged disease control with less frequent dosing and reduced treatment burden for DME and AMD patients. That was another action-packed episode. And thank you very much, Prof. Colin, Mr. Morales, for engaging us this evening.
Thank you again, everyone, for attending the 22nd episode of the VR channel. And thank you, Zeiss Philippines, for supporting this episode. So just a few reminders before we close this session. Please scan the QR code to send us feedback and receive your certificate of attendance. You can also click on the link posted in the YouTube chat box. The form will be accepting responses for 1 hour. Thank you again.
If you missed the previous episodes of the VR channel, they are available for viewing at the VRSP website. You can check out vrsp.org.ph.
Thank you, everyone, for participating. Join us again on the next month for episode 23 with Dr. Stephen Foster as he shares his expertise on retinal vasculitis and ocular cicatricial pemphigoid. See you then. Same time.
Same time, same channel.
Same channel.